Thank you for having me. So I am broadcasting to you from my house in Pittsburgh, Pennsylvania. And there is a 3-year-old in this house, so I apologize if there are any interruptions. Hopefully she will stay quiet. So when I am not in my house due to a global pandemic, I work out of UPMC Pain Medicine. So UPMC is the University of Pittsburgh Medical Center. They actually rebranded themselves a couple years ago as just UPMC because they are expanding beyond Pittsburgh. So our pain medicine clinics, we currently have 7 clinics in Western Pennsylvania. Most are in the Pittsburgh area. We do have a couple in northwestern Pennsylvania that are literally next to farm fields. So we have a good rural pain population. And I work under Dr. Ajay Wishsan, who's, I don't know if you can see my pointer, but he's right here in this picture. I understand he will be talking to you guys this fall. He sends his apologies that he couldn't be here today. And these are all of our providers that work in our clinics. We have, we're considered a hub and spoke group care clinic. So we have an average of 25 patients per day in each clinic. And we have pain rehabilitation programs, lots of behavioral medicine. We have 3 psychologists and 1 psychiatrist who are embedded within our clinics. We do lots of group treatment programs, and then we do the more standard pain procedures like epidural injections and spinal cord stimulators. I am not in this picture because I do not have any clinical duties. I am 100% a research person. And so I am in the next, the next picture, which is our chronic pain research division. So Dr. Wishsan also heads up the chronic pain research program at UPMC and the University of Pittsburgh. And so we do very traditional clinical research studies and clinical trials. Dr. Wishsan, for many years, his focus has been on studying negative affect in chronic low back pain. And we've done fMRI, and we're just getting into FNIRS research now, which is pretty fun. But what I'm going to talk to you today is our pain population data analytics research that we've done, which uses data from the electronic medical records. We use Epic as our EMR system, and then patient-reported outcomes data, and we use CHOIR for that. So we are having a research division embedded within pain medicine clinics makes us a wonderful environment for a learning healthcare system. So I'm sure you are all aware of this, this idea, but essentially it's the idea that clinical practice should inform research, and research should inform clinical practice, and there needs to be a lot more communication between researchers and clinicians. And specifically, we are following the National Academy of Medicine's pain strategy. This was released in 2011. Back then they were called the Institute of Medicine, now the National Academy of Medicine. And this is a pretty lengthy document that outlines 6 general areas to improve the quality of pain care in the United States, which historically has been pretty abysmal. And in the prevention and care section, they specifically they specifically talk about the collection of outcomes to track whether your patients are getting better or not. And so there's been a lot of talk about outcomes with COVID very much dominating the news. Probably the most common outcome that is tracked is death, unfortunately. That is not an appropriate outcome for pain medicine. So for pain medicine, the specific outcomes that we use were developed by the IMPACT group, the Initiative on Methods, Measurement, and Pain Assessment in Clinical Trials. This was a group of very prominent pain researchers and pain physicians that got together and published this very seminal report in 2003 in the journal Pain. And they outlined 6 core outcome domains. Essentially, if you want to track whether chronic pain patients are improving, you need to be tracking all 6 of these domains. So pain is obviously the first one and does seem to be the most important, but it's also important to measure whether the patient's physical functioning is improving, how is their emotional functioning, and so on. And so we very much live by these 6 core outcome domains in our research program. Now, measuring pain, which is, number 1 of those 6 core outcome domains, is a lot harder than it may seem because, as we know, pain is subjective. My experience of pain is different from all of your experience of pain. There's no way to detect pain in the brain, although I personally know some neuroimaging researchers who are working on fMRI applications that will do just that. But right now, really the only reliable way to measure pain is to simply ask the patients how bad their pain is. And that's essentially what patient-reported outcomes are, at least in pain medicine. And so there are, people have been giving pain questionnaires to patients for decades, much longer than I've been doing this kind of research. And I just did a quick Google search on pain scales. I'm sure you've all seen many different versions of these. So here's a good example of, this is a very standard pain intensity scale. Low numbers are bad, or low numbers mean low pain, high numbers mean high pain. But when you start to look at them and compare them to each other, you can see they're actually very, very different scales. So these three have faces. This one has Charlie Brown's face, which I found. There's Lego scales. There's all sorts of weird pain scales that you can find on the internet. This one doesn't have any faces on it. You can see that these three are 0 to 10 scales. This one is a 0 to 5. And then if you actually look at the descriptions, it gets even worse. So here, distressing is a 4. Here, distressing pain is a 5. And on this one, distressing pain is a 6. So if you were to give these scales to different patients, there's no way that you could compare those patients' pain to each other in any kind of satisfactory manner. And so it's really important when you are tracking patient outcomes that you're all using the same types of scales, and you know that those scales actually measure what you want them to measure, what you're trying to record. So there's been a very major initiative in the past couple of decades to develop really high quality patient-reported outcomes measures. The most prominent group doing this is the PROMIS group. So it's the Patient-Reported Outcomes Measurement Information System, so PROMIS without an E at the end. And they have these item banks, which this is a subset of the ones they have. This list is actually a few years old, and they have even more nowadays. Essentially, these item banks are 20 to 50 multiple choice questions in each item bank. And they're 5-point Likert scales, so 5 options for each question. And every single question in every single item bank has been scientifically validated. So they all have these validation statistics like slope, category threshold, and item fit statistics, which are essentially a measure of the quality of how good those questions are at measuring, these outcome domains. And the cool thing about PROMIS is that they're not just standard fixed surveys. So there are several different options for how you can administer them to patients. So they do have fixed short forms. So you can, there's a specific set of 6 or 10 questions in each item bank, and you can give those to patients or research subjects. And that's fine if you want to go that way. There are also profiles. PROMIS 29 is a really common profile. There's also PROMIS, I think 43 and 57, and the numbers are the number of questions that they have. And those actually have multiple item domains. So I think the PROMIS 29 has 8 different domains, 4 questions in each domain, and then a pain intensity scale. So if you want to do kind of a quick and dirty measure, covering a whole bunch of different domains, those profiles are really nice for that. You can create custom measures, which is pretty cool. So if you want, if there's specific questions in an item bank that you want to use, you can build your own survey with as many questions as you want. And then the really kind of their bread and butter are what are called computerized adaptive tests, or CATs. So how the CATs work, they're based on item response theory. Now, item response theory, I could do a whole hour-long lecture on item response theory, and I'm by no means an expert on it, so I'm just going to go over it in sort of very, very briefly. But essentially the theory that assumes that the responses that a patient gives to a specific question will be based on unmeasured traits. So for example, these are some examples of the PROMIS pain behavior, some of the questions in the PROMIS pain behavior item bank. And item response theory essentially assumes that a patient with high pain behavior will have high scores and answer, sort of the 4 or 5 questions. And the patients with low pain behavior will answer with lower scores. And so essentially how the computerized adaptive tests work is so imagine that I'm a patient taking these surveys. And so if I were to mark, let's say, sometimes for every answer, my raw score, which is just adding up, those raw numbers, would be 12. and my individual standard deviation would be 0 because my answers didn't vary at all on, on those questions. So, but if I was jumping around, like let's say I said that when I was in pain, I never squirmed. When I was in pain, I always grimaced. When I was in pain, I rarely groaned. And when I was in pain, I often drew my knees up. Well, now my raw score is the same, so it's still a 12, but my deviation is much larger. So that's two very different patients, even though they have the same raw score. One patient is very consistent, and so it's pretty clear sort of where they fall in terms of pain behavior, but the other patient is not as consistent. And so item response theory and the computerized adaptive tests actually adapt to those different kinds of patients. So the patients how they work is that every patient is presented with 4 questions. And what it's looking for is it's looking for the patient's standard deviation to fall below a certain threshold. So if, like, the first example, I'm being very consistent, my standard deviation is 0, the cat will stop at 4 questions and it will calculate, the score, and then it moves on. However, if the patient is jumping around and the patient has a bigger standard deviation, then more and more questions are presented until the patient falls, the standard deviation falls below that threshold. So it's a way of getting a very accurate score for each patient and adapting each survey based on that patient's individual responses. So for every PROMIS item bank, and no matter how you're administering it, whether it's a short form or a CAT, you can calculate the standardized T-scores. So the raw scores are converted to a T-score, and the T-scores are standardized to the US population so that the mean for every item bank is a 50 and the standard deviation is a 10. So if you have a patient who scores a 60, you know that they are 1 standard deviation above the general population. So there's a really cool demo that PROMIS has on their website where you can actually take some cats and try them out and play around with the different responses and see where you fall on the different scales. So I was going to show you a demo, but I don't really have enough time to do that. But I encourage you to check it out because it's actually a really comprehensive website. So we have these wonderful outcome measures that PROMIS has developed. And so then the question is, how do we get them into the pain clinics? And at UPMC Pain Medicine, we chose to use CHOIR. This was developed at Stanford University by Dr. Sean Mackey, who I understand you heard from a couple weeks ago. So CHOIR is an open source and web-based patient-reported outcomes application. Now, there are a lot of patient-reported outcomes applications that are being developed, and are in existence now. We chose CHOIR because it was specifically developed in a pain management practice by a pain physician, and so it really is optimized for our practices. And so essentially what happens, or how it works, is that the patients who come into our clinics are sent a link via email to their specific CHOIR survey for their appointment. We send ours 7 days before each appointment, and then there's a reminder 1 day before the appointment. And then if they don't complete it ahead of time, then we do have some tablets, or actually iPads, that are owned by the clinics, and so they can complete the survey in the waiting room or in the exam room. And we rolled out this system in 2016. We use it in all 7 clinics, and it has been, by and large, very, very successful. So the neat thing about CHOIR, one of the many neat things about CHOIR, is that you can customize your surveys. You can use whatever measures you want. There are a lot of them built into the sort of the standard Stanford build of CHOIR. And then you can also add your own measures. So for example, at all these PROMIS measures that are listed here, these are all CATs that are built into CHOIR. And then, so the pain detect for neuropathic pain, we added that as a custom question. That is a validated pain scale. It wasn't in the standard build of CHOIR. We wanted it, and so we were able to program it in ourselves. So essentially how our CHOIR surveys work is that we have a new patient survey, which is quite long. And then we have a follow-up survey for returning patients. We do ask every patient to complete a CHOIR survey at every appointment, with a few minor exceptions. The most common is day of procedure. We sometimes, don't get a CHOIR measure on a procedure day. So at all appointments, this is the list that we measures that we get, every time, every patient. New patients also answer all of these questions, and then at follow-up, we also get an impression of change. So essentially, overall, how does the patient perceive their improvement? I color-coded these measures based on the impact outcome domains. You can see we are actually getting, collecting measures across all 6 outcome domains. And I would argue that some of them, like the pain detect, for example, it is a pain measure, but it also, I would argue, is also a symptom measure. So there are many of these measures that actually cover multiple outcome domains. The other ones that I'll talk about, which are right now just at UPMC, but are going to be in CHOIR soon, are the HEAL measures. So there's positive outlook, treatment expectancy, attitudes toward CAM is also a HEAL measure. So HEAL is healing encounters and attitudes lists. And these are actually item banks for contextual measures that were designed to go into PROMIS and become PROMIS measures, and they may someday, but right now PROMIS wants a lot of money for that to happen, so it has not. That has not happened so far, but they are CATs, and they were very much designed to work just like PROMIS measures. Those were developed here at the University of Pittsburgh by a group of researchers in our psychiatry department. So they're pretty neat. So that's what we ask for our patients in CHOIR. So once the patient completes the CHOIR survey, then there is a report that's available for the clinicians to view. So this is an example. This is a completely fake patient, but this is an example of what they look like. So there's always a body map, pain body map at the very top, and that's the first question that's on the CHOIR survey. And then there's a list of all of the different, most of these are PROMIS measures that, but any sort of scaled measure that the patient answers, it has their scores. We do both the T-scores and percentile scores. And then for follow-up patients, you can track them over time. Again, this is a fake patient, so this is a very unusual trajectory for a patient. And then there are a list of individual questions that the patient was asked during the CHOIR survey, and then it shows their responses to those. These reports are typically 3 to 4 pages long, although there are some free-form text boxes, and I have seen some patients get kind of chatty, so they can be longer than that if the patient is putting in a lot of information. And the physicians take snapshots, basically just using the browser's snapshot tool, and then paste images of the reports into the Epic physician notes. So essentially the CHOIR reports become part of the patient's electronic medical records. So as we said, we rolled out in 2016. So our UPMC CHOIR system is now 4 years old. And so we've had, in that time, we've had over 28,000 unique patients who've completed at least one CHOIR survey. And we now have over 112,000 surveys that have been completed. We have a handful of patients who've completed more than 50 CHOIR surveys. So we're really, our old timers who've been with us a while are very, very used to completing CHOIR surveys. And really, since we started, we've had about a 70% completion rate. So about 70% of our attended appointments have a completed CHOIR survey associated with them. And we've been pretty consistent with that from the start. So we've had 4 years of CHOIR, which means we have 4 years that we've been listening to people complain about the CHOIR system. So I wanted to tell you guys about some of the really common complaints that we hear over and over again. So from the providers and the staff, so first of all, the providers, they hate copying and pasting the CHOIR, the images of the CHOIR report into the EMR. It only takes 2 seconds. But that 2 seconds, when you're seeing 30 patients a day, it just adds to the physician burden, and workload, and it also introduces human error. So we have been working on integrating the CHOIR reports directly into Epic. I could give a whole hour-long talk about that saga. Essentially, we're working on it. It hasn't happened yet. I don't know when it will. Hopefully it will someday. We've had a lot of complaints from the providers and the staff about patients just taking too long to finish the surveys. Our initial survey takes about 15 to 30 minutes on average to complete, so it is very long. And our follow-up is shorter. It usually takes 5 to 10 minutes for patients to complete follow-ups. But you can imagine, you know, especially in clinics with very high volumes, it can slow down the clinic workflow if you're waiting for patients to complete the survey. The nurses and the front desk staff do field a lot of the complaints from the patients and confusion from the patients about CHOIR. So we've really had to do a lot of training and especially giving them sort of scripts to answer the really common questions that come up again and again from the patients. And then, you know, with any hardware and software system, there are technical issues. Sometimes the system goes down, sometimes the iPads don't work. There's all sorts of bugs that have popped up. On the patient side of things, probably the most common complaint we get is that the surveys are too long. We have really tried to cut down the survey length over the years and just keep in what we absolutely need. Although I swear, if we had one question in our surveys, patient would still complain. They would still complain that it was too long. So in some ways, you just can't win. It's been really interesting to listen to the patients, or you know, see the patient's reactions to the item response theory and the CATs in particular. There are a lot of patients who say that it's asking the same thing over and over again, and a lot of them think that it's trying to trick them. And so like a good example is in the depression item bank, there's a question that says, in the past 7 days, I felt helpless. And then there's another question that says, in the past 7 days, I felt helpless. So helpless and hopeless are the two. And so they're very similar. And you could see how patients would interpret it as, it just asked me that, but it's not asking the same question. And you know, it's not trying to trick them. That's just how the CAT works. And so this is one thing we're coaching the staff and the nurses on how to respond to these types of questions has really helped with a lot of that. We do occasionally have patients who say that a particular question doesn't apply to them. So, and a lot of those are for the more custom questions that we've programmed in at UPMC. So we've added some comment boxes wherever we can, so patients can say why it doesn't apply to them. We have patients, you know, do I have to do this again? Before patient-reported outcomes became really common, patients were very much used to, you only have to answer, you know, fill out the questionnaire when you come to a clinic for the first time. And then every time you come back, you know, you just sit in the waiting room, you know, until you're called in. And so the idea that you have to answer a questionnaire every single time you visit the clinic was really something that, like, culturally it took the patients a long time to get on board. And we still have patients who complain about it, you know, just, I do it every time, do I have to do it again? And then we have patients who have problems using the iPads, who just are unable to use the iPads for, you know, a variety of reasons. So those are really our most common complaints. Now, we have had positive responses for the record. It has not just been complaints. So from the providers and the staff side, I've had several providers tell me that they find the clinician reports that are generated by CHOIR to be so useful that they actually have become somewhat dependent on them. And so when a patient doesn't complete the CHOIR survey, then they're kind of flying blind when they go into the exam room because they don't really know sort of where the patient's at. A lot of providers have told me that it's really useful for having conversations with patients. One scenario I've heard a couple of times is when patients are tapering from opioids. You know, at the follow-up visit, they'll say, my pain is a lot worse. You know, you gotta, you know, bump my dose back up. And then the provider will pull up the CHOIR report and say, well, when we started tapering you, you were an 8, and now you're at an 8. So it seems like maybe your pain hasn't increased that much, you know, and it does help kind of keep the patients, you know, reminding the patients where they were and where they are now. And so it's really helped in that respect. So prior authorizations this is a very American healthcare system issue. So insurance companies require a prior authorization. They have to approve procedures before they can be performed. And so the staff has actually found that the CHOIR report, they can fax it to the insurance companies, to show that the patient has, they indicated on the body map that they have pain in their knee, so the insurance company will approve a knee injection. So that was something I never anticipated that CHOIR would be used for, but the staff has actually found it to be very useful in that sense. And then CHOIR the physicians really, really love it as a tool for doing quality improvement research and more basic research. Most of our attending physicians have faculty appointments at the university, so they're required to do research, and it's been kind of neat to see how many of them have shifted, to doing CHOIR-based studies, now that we have CHOIR data available. On the patient side of things, so patient perceptions, I have noticed, very much flow from the provider's perception of CHOIR. So in clinics where the provider loves CHOIR, is excited about CHOIR, the patients are excited about CHOIR, and they have higher completion rates and they complain less. Whereas in the clinics where the provider is not as into CHOIR and doesn't find it as useful, the patients complain more and the response rates are much lower. So it's very much the providers set the tone for how the patients view CHOIR. I have had patients who, when they do get to see the reports, the only way they can see it is if the provider brings it up in a browser for them. But I've had patients say that they really like seeing their progress, where they're improving and where they, still need to improve. Several of them have told me it makes them think about their pain differently, and that is a documented phenomenon that happens when you administer surveys to, really any kind of survey. As soon as you start asking someone questions about something about their health, they think about it differently than they did before. And we have had patients request copies of the CHOIR report for other providers, like their primary care providers and for psychologists, because there really is a lot of very useful information in the report, and it is a really nice snapshot of how the patient is doing across all these different domains. So two really common questions that I get or that I hear are, why do I have to answer these questions? And is anyone looking at my responses? And so my answer to that is that UPMC CHOIR has 3 functions. So it is a clinical decision-making tool, and I already showed you the clinician report and talked about sort of the clinic side of things. We use it for quality improvement within UPMC pain medicine, and then we also use it for basic and analytical research. So whenever anyone asks, is anyone actually looking at this? I say, well, I am all the time. That's most of my job, actually. So, so I wanted to talk a bit about our research infrastructure and how we set that up and sort of how things work on the research side. So the most important part of doing research on patient-reported outcomes data of any kind is how you manage your data, because it is a lot. We have a table in our database that has 19 million rows in it. You cannot use Excel to analyze that. You really need some more higher powered tools and applications. So essentially what we have is we have our CHOIR, every question that a patient answers, that data goes into our CHOIR database. And then we also, so that's sort of this side of this figure here. And then we also were able to set up a filtered read-only view of the electronic medical records for specifically for our pain medicine patients. So we can't see any patients who, don't come to our clinics, but for our patients, we can see their appointment information, the medications that they are taking, prescriptions, procedure orders, that sort of thing. And so those two databases are linked together, and we call that our Patient Outcomes Repository for Treatment, or PORT. We have a lot of nautical acronyms that we've come up with for various parts of this. And so that's our database. And both of those databases are Oracle databases here at UPMC. Which means that you need someone with knowledge of the SQL programming language in order to access the data in those databases. Now, there are other database systems that are based on other languages, but essentially there is so much data here, and it is so complicated that you do need someone who has some skills, programming skills and database skills in order to do anything with this data. So the first step whenever you do, what we call the queries is what you call getting the data out of the databases, is data processing is the first step. It is the step that takes the longest, and it is the most important thing to do. And this can be anything from de-identifying data, which we basically, anything that goes off of the hard drive of my computer needs to be de-identified for the most part. You do things like flagging patients who've had particular treatments, or have particular characteristics that you're interested in. We do a lot of custom variable creation, sort of recoding data so that it fits, what we need it, or a format that we need it to have. We do case control matching. There's all sorts of different things that you need to do in order to get a data set that you can actually analyze. It is extremely rare that you can just query data directly from the database and you're ready to go right to the analysis stage. So don't overlook data processing. It really is very labor intensive and takes a lot of time. So in terms of the type of research that you can do, I wanted to just kind of give you guys an overview of the different kinds of research that we've done, because this isn't just tracking patient outcomes. There's a lot more that you can do with this type of data. So the first thing we did, which is the table 1 of every, clinical trials publication you've ever read, is we just looked at our patient population. And this, I thought this was super fun because, this is not a clinical trial. These are not research subjects. This is our entire population of our patients. And so, we have about 60% women. Western Pennsylvania is not super diverse, so we're about 80% white patients. We have an older population, so 57 is the mean age. Average pain intensity at baseline is about a 7 on the 0 to 10 scale. This is an interesting graph. So pain experience duration is pretty cool. So you can see like the biggest group of patients has less than 1 year of pain experience when they come to our clinics, but the mean pain duration is actually 7 years with a very, very large standard deviation. And that's because we have a lot of patients who have had pain for a long period of time, and we have patients who are 100 years old and have had pain their entire life. So their pain experience duration is very long. So this is a graph with a very, very long tail. So Medicaid insurance, for those of you who don't know, it's a US federal government program, insurance program for people who live below the poverty line. So this is the only reliable socioeconomic status indicator that we have in CHOIR. So essentially this means that we have 21% of our patients live below the poverty line. 9.8 regions collected on the body map on average at baseline. And then here are the PROMIS scores at baseline for average PROMIS scores for our patients. And remember that the PROMIS T-scores are all scaled so that the general population mean is a 50 and the standard deviation is a 10. So you can see for pain interference and physical function, our patients are very different from the general population, as you would expect, for a chronic pain clinic. We do tracking outcomes. This is not all we do, but this is, one of the first things that we did is just looking at our patients at their initial visit, and then at 3-month follow-up. We've also done 6, 9, 12, 24-month follow-ups. So this is just the MCID, minimal clinically important difference response at 3 months. And so the impression of change, so this is the patient's perception of how well they've improved. About 56% of patients actually meet minimal thresholds for improvement for impression of change. 50% of patients meet MCID thresholds for either pain intensity or physical function. And then you can see for the other measures, sleep disturbance, depression, anxiety, and then physical function and pain intensity alone, about a third of our patients are meeting MCID thresholds. And Dr. Hassan always likes to talk about the 30-30-30 rule, which is that about 30, in pain medicine, about 30, a third of the patients are getting better, about a third of them are getting worse, and about a third of them are not seeing any major change. And that does seem to track with what we see in CHOIR. So, so we got confirmation of that. So in our, as I said at the beginning, we are really a wonderful example of a learning healthcare system. And part of that, I think that the most important thing for establishing that has been really establishing a close relationship between, the researchers like myself and the clinicians. And so here's an example of a study that, emerged because literally our pain psychologist, Sue Harkeen, walked into my office about a year after we finished rolling out CHOIR, and she said, can we use the CHOIR data to figure out if I'm actually helping my patients? And I said, Well, yes, but let's reframe that as a research question. That's a very existential question. Let's reframe that as a research question. And so what we ended up doing is we got some statisticians on board, and we did what's called propensity score matching. So we identified 453 patients in what we call the behavioral medicine group who had seen one of our pain psychologists at least 3 times. And then we had a group of standard care patients, over 8,000 actually, who had never been to any of our clinic psychologists or psychiatrists. And so what propensity score matching does is we had 12 baseline variables. And what it does is it actually, it's a form of case control matching where we actually were able to weight the standard care patients based on how much they, how similar they were to the behavioral medicine patients. So patients that are more similar to the behavioral medicine patients were weighted, higher, and then, lower weight was given to the patients who were less like the behavioral medicine group. So that meant that you can use your entire, all available patients, and everyone is properly weighted, and you don't have to throw out, 8,000-ish of your standard care patients. Then we did this weighted general linear mixed model, mixed modeling with continuous time intervals. We looked at baseline evals up to 12 months, and there were 14 outcome variables actually that we looked at. This paper was just published in Pain Medicine a month or 2 ago. So the answer to Sue's question, does behavioral medicine work for our patients, overwhelmingly was yes. And what we found is that at baseline, as you would probably imagine, the patients who were sent to see the psychologist are worse on almost every measure: worse pain, worse anxiety, worse depression, worse sleep, worse physical function. They're also more likely to be a member of a minority race, more likely to have low socioeconomic status. I mean, this is a very, very vulnerable patient population. And what we found is that actually at, all the way up to a year, both the behavioral medicine and the standard care patients improved significantly on all these different measures. And what we found, there actually seems to be an additive benefit of behavioral medicine, because behavioral medicine patients actually had an improved impression of change compared to the standard care patients, which means that they actually perceived that they were more improved compared to the standard care patients at follow-up. So one of the reviewers on this paper, actually, who was a behavioral medicine researcher of some kind, said that any pain psychologist would be delighted to see these results. And it's probably the nicest thing a reviewer has ever said on any paper I've written. So, so that was really neat to see. So in another learning healthcare system project that we did, this is Impress in Pain Medicine. It should be out in a couple of months. So Cheryl Bernstein is one of our attending physicians, and she walked into my office one day, and she said that she had a hunch that her patients that were taking opioids were, whenever she recommended that they go to the psychologist or they do PT or OT, that she said they just never seem to do it. And she said, can we use CHOIR to figure out if that's true? And I said, yes, but let's reframe that as a research question. So what we did is we identified 236 patients at initial eval, and then tracked actually 2 kinds of outcomes in this one. And this is an example of a study where we actually had to do some additional chart review, because the outcomes that we had, which were tracking which patients were recommended non-pharmacological treatments and which patients who were recommended then participated in those treatments, that was something that we didn't have the variables in the CHOIR database. So we actually had to do some chart review in order to get those outcomes. And we did a binomial regression analysis with what's called feature selection. And so what that does is we had 38 variables that we looked at all together. And what feature selection does is it actually kind of pits all the variables against each other, and then it picks out a subset that actually have some predictive validity. And then within that subset, then you actually, that's where you actually do the statistics to find out which ones are significant. So you kind of get sort of 2 tiers of results there, because you see which variables are predictive, and then sort of what's not predictive for future studies. But then within those predictive variables, you can see what is significantly predictive. So this is an example of a predictive analytics study. So in a nutshell, what we found is that for predicting who is recommended non-pharmacological treatments, it's female patients. patients with a spinal pain diagnosis in the M51 ICD-10 category, and then patients with buttocks pain. Those were the patients that were more likely to be recommended those types of treatments. And then the biggest predictor of non-recommendation of those types of treatments was being on long-term opioid therapy, which makes sense, because if they're doing well on opioids, there's probably not much reason to try a PT or something like that. But going back to Dr. Bernstein's hunch that she had, which patients will participate in non-pharmacological treatments, we actually found that, so this is the relative risk ratio here. So patients who are taking Schedule II opioids were 90% less likely to participate in a non-pharmacological treatment when it was recommended. We also found that regardless of other patient characteristics, when rehab therapy was recommended, so PT or OT, patients were 86% less likely to participate in those treatments. So patients don't like going to PT. And it does seem that Cheryl's hunch was right. So that's in press. It'll be out in a few months. So we've also done some machine learning, and Dr. Bassan will probably go into this in a little bit more detail when he talks in the fall. This is a study, a machine learning study we did with Ben Alter, who's another one of our attending physicians. So what we did is we took the body map, literally just the body map and all the regions that were selected on the body map. This is a set of 22,000 patients, which was essentially every patient we had in the system in the first 3 years of CHOIR. And we took their first body map, and we did what's called a hierarchical cluster analysis, which is essentially grouping patients into clusters based on similarity in body map patterns. And so what we did is we actually were able to identify there's 9 clusters. So these are essentially the 9 patterns of pain that you see in chronic pain patients. This is still a work in progress, but what we found then once we identified the clusters, then we started to look at outcomes and and different characteristics. What was interesting is that so these clusters are entirely based on the body map. There's no other variables in that analysis. But when you look at their baseline score, so their anxiety, depression, other characteristics, these patients are wildly different, the patients assigned to the different clusters. So there does seem to be something about the pattern of pain that actually has some link to the emotional functioning and physical functioning and all these other outcome measures that we look at. The other thing we found is that there's 2 clusters that had widespread pain. So these are essentially fibromyalgia patients. There's one that had a very heavy pattern of pain, one that had a lighter pattern of pain. These 2 groups had much poorer outcomes compared to any of the other groups of patients. So this is still a work in progress, but that's an example of some very cool machine learning that you can do with this type of data. So to sum up, patient-reported outcomes research is very, very doable, especially when you have a learning healthcare system set up. There's lots of different options for the type of research that you can do. It is very important to establish your data infrastructure first, and you have to have buy-in from clinicians and clinical database managers and hospital administrators, and everyone kind of needs to be on board to get this sort of system up and running. We've also found that it is absolutely critical to have a multidisciplinary, clinical, research team, where we have clinician, clinician researchers, peer researchers like myself, statisticians, database people, because these are really complicated studies, and you really can't manage there would be very few people that would be able to manage this type of study from beginning to end all by themselves. You really have to have kind of a lot of different skills to be able to do that. And we've also found that, initially when we had the data, I could, in theory, I could handle things, on the data end myself, but I don't have the clinical expertise and I don't have the ideas to come up with the studies that need to be done. And so I think that really argues for the learning healthcare system, that you really do need both clinicians and researchers to be talking to each other and walking into each other's offices in order to do this kind of research. So that is all I have. I am happy to take questions, and thank you for letting me talk.